So earlier on in the pandemic, the vast majority of kids had an asymptomatic or minimal infection, minimal symptoms, fever, cough, fatigue, some aches. Some got hospitalized, most stayed on the floor and got oxygen. Some did have severe pneumonia with what would be considered respiratory failure, needing to stay in the ICU, needing to get intubated. This seemed earlier on in the pandemic to be much worse in teens, and there's a lot of data on risk factors for severe COVID-19, mostly from that earlier phase, which includes some things that are true for both kids and adults, some that are more true just for kids, but includes things like lung disease, including asthma, neurodevelopmental problems. So this is everything from kids who have severe developmental delay due to brain injury when they were, say, born premature, all the way to even kids with learning disabilities and autism seem to have, for whatever reason, a more severe course. Obesity, Latinx heritage, type 1 diabetes, and being immunocompromised are all risk factors that we saw more before. They are still relevant, but a little bit less so. Currently, with Omicron and some of the variants we've been seeing more recently, still a vast majority are asymptomatic, but it seems even fewer have fever. Some of this is because more kids are vaccinated. Some of this is because Omicron seems to cause more of just sort of upper respiratory disease. Some do get hospitalized. In the kids who get hospitalized, it seems Omicron presents differently. They look more like kids who have croup, sort of a barky kind of dog-like cough, or you might have heard, if you're a parent or grandparent, about bronchiolitis or RSV, sort of a viral kind of pneumonia sort of picture. And in this case, it seems to be worse in kids under 5. Most of that, some of that is due to the vaccine, some of that is due to the smaller airways in kids that age, and really seems most severe in infants and toddlers, which is true of croup and bronchiolitis in general, even from other viruses. The risk factors really seem more relevant for older kids, and the younger patients we've been seeing have been more likely to be otherwise healthy. And we would see kids who were vaccinated get hospitalized, but there was definitely a significant trend towards kids being unvaccinated. The other big thing we worry about in kids, which you may have heard about, is this MIS-C, multisystem inflammatory syndrome in children. This is a rare post-COVID hyperinflammatory process. How rare? It's about 1 in 3,500 kids. It's still occurring after Omicron infection. It seems maybe to be less severe, or at least a little less typical, but basically about 4 to 6 weeks after the infection, in 1 in 3,500 kids or so, we'll see prolonged fever and irritability. Sometimes you can see rash, sometimes you can see GI symptoms. They might have red eyes, they might have cough. There can be other infections. Earlier on in the pandemic, we saw this more in older kids, and as the age of infection is moving younger, obviously this is moving younger too. Still can have some major problems in terms of damage to the heart, which is kind of the big concern with MIS-C. But as of at least last month, we've got a really good study that came out that shows that it's prevented by vaccination, that 1 in 3,500 risk, which is pretty low already, drops to 1 in a million if you are vaccinated against COVID-19. So that's pretty fantastic. Long COVID. This is definitely something we don't know a lot about. There's more data in adults, but after you're about 1 to 2 months out from the disease, we don't have a lot of data in kids or teens. There are case reports that kids can have neuroautoimmune phenomenons. So people might have heard of something called Guillain-Barré, which you can get after a viral infection, and it can cause paralysis that kind of works its way up from the bottom of your body, from your legs on up. This thing called ADEM, which can present with sort of weird transient neurologic symptoms, almost like kind of a short-term MS that then gets treated with steroids and goes away. And those are pretty scary. We don't totally know. I mean, they're very treatable, but we don't totally know what causes them and why they seem to be cropping up after COVID, other than that they crop up after a lot of infections, and we don't really have the data yet to know if it's more after COVID versus others. There seems to be maybe a trend towards general autoimmune issues rising up. We've had more people presenting to our rheumatology offices in pediatrics at Albany, and when I was at Stony Brook. Is this because people are more worried? It's really hard to know. And even in adults, it's pretty unclear what you do for this other than treat the symptoms. There's not any indication that it's necessarily persistent infection, although there's been some suggestion of that in some adult data. But even with that, up until recently, we haven't had good outpatient treatments, so it's not even been clear what one would do with that information. So this is something that people are still very much studying and learning about, and unfortunately, I don't have great answers for. So how is COVID transmitted? It's transmitted through the air. We know this. And despite some debate sort of earlier on in the pandemic about is it droplets, is it aerosols, and how big are the particles, essentially it's aerosols. And you can argue about what size an aerosol is. And in medicine, we had previously considered things that were aerosols much smaller. And then people from materials science were yelling at us. And there was all these articles and journals back and forth and back and forth. Basically, the important thing is that it's small particles that can stay in the air for hours. So this is why, especially early on, it was important to limit the amount of time you were in a room. It was important, and still is, to have ventilation, and why masks were helpful, and still are helpful, but we'll talk about that. The one thing that's been a huge change is the number of people that one sick person can infect, how infectious COVID is. So this is a number that people have probably seen being thrown around in articles that we call the reproductive number, or R sub 0. So for example, for Ebola, which everyone was really worried about, it's about 2 people. One person who's sick will transmit it to 2 people. For flu, it's around 2 to 3 people. The original COVID-19 strain was about 3 to 4 people. Every major spike since then has increased that. Delta doubled it to about 7, and Omicron doubled it again. And there's even some hints that the BA2 subvariant of Omicron may be even more like measles. Why is this important? First of all, it just sort of emphasizes how much easier the variants are to get transmitted, how well they're adapting to us, spreading them around, which is ultimately what the virus wants from sort of an evolution standpoint. But it also, when you think of it in perspective compared to something like measles is a disease, because of how contagious it is, that you really need high vaccination rates to prevent any transmission. You need something like 90% in a community to keep measles from being transmitted. And when it drops below that, we see outbreaks like one a few years ago in Disneyland, and outbreaks there have been in Orthodox Jewish communities in Brooklyn and upstate New York. We're approaching that with COVID-19. Now, it's not as severe as measles for the vast majority of people, but it just gives you kind of some idea of how contagious it can be. And the reason for that is that the new variants really have a predilection for the upper airway. The older variants love the lungs. There's all sorts of stuff about the ACE receptor and binding to cells and tissues in the lung. Omicron and the Omicron subvariants love binding to and hanging out in the upper respiratory tract. So that's good in that it means you don't have as much pneumonia and severe lower respiratory tract disease, which is what leads to people getting intubated and winding up on ventilators in the ICU and everything. But it also, unfortunately, means it's that much easier to transmit. The one bright side of this is likely the virus adapting to us as hosts, as opposed to the animal that it came from initially. And it is in a virus's interest, as it adapts to a host, to be less harmful to that host, to cause us to live longer, to transmit it more. And so usually, along with becoming more contagious, viruses will also get less severe over time, which again seems to be what we're seeing. So I take that as a good sign that it's becoming more contagious, especially as we get better able to treat it, because it's a sign that it's moving towards maybe becoming more like a cold virus or a flu or something, though more contagious than the flu. And so, yeah, sorry. So that's Omicron transmission. I forgot I had that silly transition. Sorry. So with it being this transmissible, what about masking? Do they work? Yes. That question mark is purposeful. So overall, early on, large body of data from early in the pandemic supporting masking in adults together with other interventions. So you reduce crowds, you increase ventilation, you minimize your time indoors. As the pandemic goes on, as this virus has become more contagious, the data gets a little bit more hazy, especially with regard to children. So there was an article I guess the point it might have been a couple of months ago, in the Atlantic, which I was sort of surprised to see, written by a couple of doctors and scientists, questioning whether masks really worked in schools. And at first I sort of thought, gee, this seems sort of atypical for what the Atlantic usually publishes. And then in reading it and looking through what they were referencing, it told an interesting story. So early on, the CDC had some data showing that mask interventions worked in school. There was a study in summer 2020 that showed benefit to masking in teachers and adults. So you could decrease both adult and children's infection with masking of adults. Over the course of the first, really year and a half of the pandemic, there were some studies that showed that masking of kids helped, but when you looked into them, what you realized was they weren't controlling for adherence to masking. So they weren't looking at all at whether kids were actually keeping the masks on their faces, which with my own 2 kids, I can tell you the stories they report back from school is that does not happen. Kids are going around with their masks below their noses or off completely. There's not great enforcement. And they also weren't controlled for vaccination. So most of the school districts that had very lax mask policies didn't have great vaccine policies, but there were some where, a county or a state might have had one mask policy and a more stringent vaccination policy, or vice versa. And when you try to control for vaccination, or when the authors of this article in the Atlantic did, it looked like the impact was more from vaccine than from masks. And again, maybe because kids just aren't good at wearing their masks. We know it matters in adults. There's data from the beginning of the beginning of the pandemic that shows that. So just this month, we've got a new study that was published in Pediatrics that claims to have shown that districts with optional masking had 3.5 times the amount of secondary transmission, of sort of looking at, like, you've got a transmission event that happens in the community, how much further spreads, what we would call secondary transmission, happens in a school. And it was 3.5 times that of districts that had universal masking. And it was a relevant number. It's not like 3.5 times like 3 in a million versus 1 in a million. It's 26 cases per 100 versus 7.3 cases per 100. So out of every primary case, 1 in 4 versus whatever 8 in 100 is. 1 in I can't do that math in my head. 1 in 7 or something like that. No, that's probably not right. It's 1 in 12, 1 in 13. Anyway, sorry, I'm a doctor, not a mathematician. So anyway, this seems like this is great data. The problem is, despite them saying in the paper that they looked at vaccination rates, they didn't actually control for them. So if you look at vaccine requirements in the districts, they had 61 districts they looked at across a bunch of states. When you look at vaccination rates in the states, it was everywhere from California to Texas. Most of the districts were in North Carolina. Vaccination rate in Texas was around 54%. The one in California was over 70%. So statewide, there were definitely differences in vaccination rates. And if you look at the vaccination rates in the surrounding counties, which is the lines I haven't circled, the bottom 2 lines, you can see that actually universal masking policy places had a lower vaccination rate in the surrounding counties than those that had partial, those that had optional masking policy. But when you look at whether the vaccine was required for staff, and you can't really require it for students because the vaccine in kids is still only an EUA, you can't really require an EUA vaccine yet. 13% of the universal districts required vaccine for staff and none for the other districts. They don't comment on this in the paper. They don't actually say either way whether they controlled for this or whether this could be a factor. And so sort of critically reading this paper, it could be that vaccination was a factor in this. I mean, not obviously for all of the universal masking districts, it was only 13%, but 13% versus 0 might be enough of a significant difference to have affected things. They do note that in certain schools where they had adherence data, over time, there was a trend towards adherence mattering and being statistically significant. So if they had bump ups in their cases, they would really crack down on mask wearing in the kids, and that did seem to help sort of within a same school. So that's sort of almost a bit of a control for vaccination, because the vaccination rates within the school probably didn't change much, maybe a little bit, but that does make a case that kind of the big factor is probably adherence. And so I think, in my opinion, I don't know what was going on in the CDC's head when they changed their guidance on masks in schools. I think if you're sort of thinking about the big picture, masks do work. They work probably better in adults than they do in kids, because kids' adherence isn't great. They do work together with vaccines, but it really depends on using them properly. And so I think the CDC was sort of reading the room, seeing how tired people were, seeing how poor adherence was getting, especially in kids, and said, honestly, it's better to not even recommend them or not require them at this point if people aren't going to be using them properly. The other piece is, when you're talking about viruses that are as contagious as Omicron is now and as measles, you're really talking about preventing infection using an N95 or a KN95. The hospital masks that even we use around the hospital when we're just walking through the halls, as opposed to the N95s we use when we're with patients, probably don't add very much. And so between questions about the type of mask that should be being used and whether people are even wearing them properly, I sort of get how we got where we are now, but it is sort of interesting when you delve into the data. I think it's worth sort of, I think masks do work, but you have to kind of use them properly and choose the right ones. And obviously vaccine is probably an even bigger factor. So COVID-19 vaccination. So technically it's a SARS-CoV-2 vaccine, or we vaccinate against viruses, not diseases. But I would argue calling it a COVID-19 vaccine at this point is probably what makes the most sense, because with current variants, and especially in children, you are actually really preventing the disease more than you are the virus. In an ideal world, you would like a vaccine to prevent any SARS-CoV-2 infection, to prevent transmission, and of course, to prevent severe disease and death. The most recent vaccine data, especially as we start to see the data from the Moderna vaccine that they're hoping to release in kids 6 months to 5 years, the revised data in the 5 to 11-year-olds with Omicron, the vaccine does number 3 really well. It still does a really good job of preventing severe disease and death. It doesn't do as good of a job as for Omicron, and as the variants change more, in preventing transmission or any infection. And you could make the argument, as the virus becomes more mild and as we're better able to treat it, maybe it doesn't have to prevent infection in everybody as long as it's preventing severe disease and death. What are we talking about with a vaccine? This is, probably everybody's heard a bit about mRNA vaccines and the amazing science behind them, but just to kind of go through it for people, not in as much detail as this shows, you've got some messenger RNA that's inside a little, basically lipid fat vesicle that gets injected in. Messenger RNA, because it's just very temporary. It's what our body uses to basically carry the information from DNA to making a protein. It enters the cell. Our cells have 2 ways of kind of dealing with foreign material that's in them. One is that it recognizes if there's foreign RNA that's inside them, which would mean that they were infected with a virus, and it processes that, and it shows it, or it processes rather the protein. Once the protein gets made, the mRNA goes away, excuse me, and it shows that protein on the outside of its cell to passing T cells. The other thing that can happen is the protein ends up in a vesicle inside the cell, and it gets shown to a different, with a different protein to a different type of cell, and that leads to antibody production. Point being, you get both a T cell response and a B cell response. You get the full sort of spectrum of responses that you get with an actual viral infection, which is why this vaccine has such a strong immune response, why our arm gets so sore, why people have fevers, and why, at least with the earlier variants, it was so effective. So should I vaccinate my kid or my grandkid, or should my neighbor's kid get vaccinated? There are a lot of benefits of vaccination. So the vaccines, even now, even with the less good data against Omicron, and I'm sure they will eventually reformulate vaccines to be more effective against new variants. There's processes going on right now, and the companies are talking about that. Protection against hospitalization or worse is at least 50% or better, ballpark. Protection against MIS-C, that's a huge one, because that is a really potentially dangerous thing in kids if untreated. That's nearly 100%. And there's probably some benefit to preventing spread or herd immunity. So if you've got someone in your house who's too young to be vaccinated, as we'll talk about, or who's immunocompromised, vaccinating everybody else around them certainly isn't going to hurt. Safety. So a lot of people were worried about these vaccines in adults and in kids. It's only in EUA. It's not full approval. They still had full safety testing. That when you look at how the studies were done, they used the same number of patients. They used the same length of sort of early safety follow-up that every study does. Typically, the long follow-up for approval is because you need better efficacy data over time. But that said, sometimes you do uncover safety events later. The big one that we found with the COVID vaccine was myocarditis in sort of older adolescents and young adults. So what's the deal with myocarditis? It was a concern. We definitely saw a lot of kids in the weeks after the real bump in vaccine when it started in 12-year-olds. We saw kids come in with chest pain. Initially, probably more of them got hospitalized than needed to because people were a little bit nervous and weren't sure what to do. But we did see a bump of that, more than expected, more than we would for viruses. It's clear that the vaccine does lead to that. However, when you look at the numbers, you're talking about 8 to 10 cases in women, 15 or in young women, I guess 56 to 69 in young men. This is for every million vaccine doses. That's in 12 to 17-year-olds. And as you get older, it goes down. If you look at the preventable hospitalizations, preventable ICU admissions, and preventable deaths in those age ranges, the numbers, forgetting about cases, just looking at hospitalizations or ICU admissions, the numbers hugely outweigh the myocarditis numbers, and you're preventing, potentially, depending on which group you're looking at, in females, more deaths in the 18 to 24-year-olds and 24 to 29-year-olds than you would get myocarditis cases with the vaccine. So ultimately, the benefits of the vaccine, as well as preventing MIS-C, which is associated with a lot of cardiac effects, you're preventing a lot more cases than myocarditis. I mean, just MIS-C alone, it's 1 in 3,500. This is, 69 per million is less than 1 in 3,500. So I would think in the general consensus of most pediatricians is that while yes, the myocarditis risk does seem to be a real one in that age range, the benefits of the vaccine vastly outweigh that. Does the vaccine actually work? So children over 12, the Pfizer vaccine with the booster, even against Omicron, seems to get good protection. Children under 11, not good against Omicron. I mean, preventing infection, it's practically useless, and it's 40 to 50% in preventing, moderately severe disease. The real reason for that is essentially the dose of viral protein in the vaccine. It's usually the case that they will change the amount of viral protein or viral RNA or whatever the stimulant of the immune system is. Sorry, in this case, it's RNA in vaccines for age. Usually younger kids have more robust immune systems, and so you don't need to use as much. It seems like for whatever reason, people's response to the COVID vaccine is a little bit different, and they may just have gone too low with children under 11. The dose is 10 micrograms versus 30 in teens and adults. It's even lower in 6 months to 5 years, which is why that vaccine, they had to sort of go back to the drawing board and trying to add a third dose. And it's going to be quite some time probably before we get a Pfizer 6 month to 5 year vaccine. That's only 3 micrograms. That's a tenth of what they're giving adults. usually the doses aren't quite that different. And this maybe was a casualty of sort of trying to do it quickly and the EUA process, that they were trying to ramp down from adults to kids and get stuff out as quickly as possible. And they guessed wrong with what doses to use. It's, at a certain point, it's hypothesis testing, and this hypothesis failed, and they'll need to go back and try different doses. Moderna uses a much higher dose. And so they're dropping down from adults to kids, but in the 6-month to 5-year vaccine that they're submitting to the FDA, it uses 25 micrograms per dose of their product, which is a little bit different. But it seems like their vaccine has a much more robust immune response. It's still like maybe 50% effective in preventing severe disease, but that's obviously better than the Pfizer 6-month to 5-year product that practically didn't work at all. And so really these issues with efficacy, obviously the virus mutating and Omicron not being as good of a match is a huge one, and new vaccines that are better matches for new variants, which will come eventually, are going to help with that. But putting that aside, it seems like it's really all dose related, and that if you can just find the right dose that stimulates the immune system enough, you'll be able to get a vaccine that's as effective in kids as in adults. It's just our immune systems are different from kids, and so it takes some tinkering. What do we do about those who are too young to vaccinate? So there's some good data about this that came out pretty recently in February in JAMA Pediatrics. We have data that vaccination in pregnancy provides about 6-month antibody protection to infants. It is better than natural infection in pregnancy at antibody that get transferred across the placenta to babies. And it's definitely safer than natural infection in pregnancy. I can tell you the number of babies born to moms who were on their way to an ICU from COVID during the pandemic was way more than I would ever want to see. There was for data other than sort of my anecdata, there was a Yale study of 46,000 pregnant women that showed the vaccine did not increase prematurity, did not increase birth defects, was safe for moms, safe for the fetus. And so for people who haven't yet had a kid, getting the vaccine during pregnancy, maybe sort of during the last trimester when the antibody transfer is is kind of really happening at its peak, is a really good way to protect that eventual newborn baby. The other one is breast milk. No reason to think it wouldn't be, but there are studies that show, as with every other antibody that the body makes, neutralizing anti-spike protein antibody is transferred through breast milk to infants, resulting in blood levels in the infants of anti-spike antibody. And so that, as long as somebody is breastfeeding and as long as the mom has decent levels of antibodies, which may only be a few months between boosters, is a really good way to protect an infant. And then cocooning is a proven strategy with every other vaccine preventable disease, which is you just vaccinate as many people as you can around that unprotected infant, sort of like you would for someone who's immunocompromised and can't get the vaccine. So both the parents, any grandparents live in the house, any siblings who are able to be vaccinated, the fewer people around that infant who can't be vaccinated yet, the fewer people around that infant who could get COVID, the better. And that works for pertussis, it works for a lot of other things. There's no reason to think it wouldn't for COVID, vaccine efficacy being the main thing that would cause some difference in the numbers. The other big thing is, just to sort of mention, and in case people end up having questions about this, is other lasting effects on kids. So there's been plenty of news stories about this, and this is probably no surprise to any of us. Huge increases in the outpatient arena in children with anxiety and with depression. Inpatient, we've been seeing way more suicide attempts, whether they're just gestures or attempts that were real attempts that we managed to save the kid. My own 13-year-old and 9, almost 10-year-old have dealt with fear when we had no vaccine and they were afraid that their parents were going into work to get COVID and die, to anxiety, isolation, boredom, frustration with other people not masking or getting the vaccine, anger. And they hear us talking about it probably more than we should let them. And as we all probably know, kids really absorb it all, whether we think they do or not. And if they're not hearing about it at home, they're hearing about it at school, they're picking up on how other people are feeling about the pandemic. They're hearing about people's worries. They're hearing about people's frustrations. Really talking openly with them, letting them know that you're there. Sometimes even having the conversation with kids can help us. I've found sometimes it's helped me with my anxiety because I've been worried about how my kid is doing. And after talking to them, it turns out they're doing better than I thought. The other sort of flip side to this is kids are really resilient, and things like how are they going to adjust to masks? My daughter forgets she has her mask on when she comes home and leaves it on. And sometimes like halfway through dinner, she's about to spoon a piece of food into her mask and you have to remind her to take it off. They get used to change a lot of times better than we do. And so that's the plus to this, is that this is a new world that we're all navigating, but kids may be a little more plastic than we are. And so despite all of these lasting bad effects, may be able to navigate it with their changing brains a little more easily than we can. And so with that, it's question time for anything that I didn't answer or any new questions people have. And so I will stop my share.
Thanks so much, Saul. That was really educational and informative. And thanks to everyone who submitted questions ahead of time, because I think that Saul was able to kind of tailor his discussion towards many of those questions that were asked ahead of time. So a couple of I guess just one question that had been asked previously was like, do we have enough information to know the COVID vaccines are safe for kids and at what age? And it's a question I get asked a lot about, that I think all physicians get asked about vaccine safety. Just forget about COVID vaccine safety, but just given that it's a new vaccine or new technology, those sort of things, could you just speak to the safety of it?
Yeah, I mean, from a new technology standpoint, it really ultimately what's going on, there's one extra step involved, which is that the mRNA in the vaccine gets turned by your cells into protein. After that, it's the same as any other vaccine that delivers protein to you. People's concern about is the vaccine going to rewrite your DNA? Is it going to do other things? The mRNA is in your cells for like, I don't know, minutes, maybe hours tops, and just doesn't kind of have the ability to do that. To me, I think we've got the safety data. Sorry, I'm hearing a weird echo. I don't know if that's bothering other people. Sorry, let me just double check that my, okay. I think the vaccines aren't as efficacious as we would like. We did, I think the myocarditis thing threw some people and made them worry, are these vaccines as safe as we think they are? And there's always, with every vaccine, the potential for finding safety things that you didn't know about after the fact, even if you do a study for years. These, when you look at it overall, are actually, even taking that into account, some of the safer vaccines that we've got. I think that the data really sort of speaks for itself. I mean, 46,000 pregnant women doesn't cause issues. Even the cases where it causes myocarditis, it's in the tens per million doses, and obviously the impact of the disease is much greater than that. I gave it to my own 2 kids the instant that I could, and encourage every friend of mine and family member to give it to their kids as well. And I wouldn't do that if I didn't trust it and think it was safe. I would never recommend something to a patient that I wouldn't do myself. And so I do feel comfortable that they're safe. I get it that people are nervous. I don't know that we'll ever have better data than we do now. So
just on those lines, it was one of the questions when I was, thinking about vaccinating my kids, which again, I vaccinated them as soon as it was actually available. But when we knew that was going to be coming out, was one of the things that many people had told me was that, most of the vaccine safety events that occur are really within the first few months, and it is the short term. There really isn't a historical long-term effects from the vaccine, as opposed to with actual COVID infection. So I think that probably also speaks in terms of safety of the vaccine. So if I heard you correct, go ahead.
Sorry, I was going to say, we do have data about, say, MISC, for example, that in people who didn't have COVID but had the vaccine, it does not occur. So the kinds of immune triggers that COVID can sometimes seem to have, the vaccine, despite it triggering an immune response, really doesn't seem to do that. And that we are starting to have, some longer term data out from. So yeah, sorry.
Great. So there were a couple of questions in the chat. The Pfizer vaccine data in children ages 5 to 11, the longer term data is a little bit less than stellar, as you presented. So one of the questions was, should children under 12 who had Pfizer get a Moderna booster?
So I don't believe that we've got Moderna vaccine approval at any age under 18. This new vaccine approval that they're submitting is 6 months to 5 years. And so there's this odd gap with Moderna between 5 years and 18 years. So no, I mean, I can't recommend getting a booster since we don't have any data on it in that age range. Someone over 18, I think the Moderna is probably, there's a lot of data that it may be a little bit better than the Pfizer vaccine. And so I think, the CDC has already said mixing and matching is okay. And so I think getting a Moderna booster makes sense for adults. And I'm kind of pleased that the Moderna might make it to market before Pfizer, because they do seem to be making it a more immunogenic vaccine that might make it to market before Pfizer for the younger kids. But yeah, in that younger age range, we're stuck with Pfizer for now.
Great. And is there a minimum amount of breast milk infants should consume to see antibody benefits?
It's a good question. All of the data really seems to be every little bit helps. There's a lot of antibody in colostrum. So I think even people who aren't going to fully breastfeed will try and start so that babies get some colostrum at the beginning. Breastfeeding in general it's a personal choice. There's a lot of factors that go in, from social to biological. And I think, people should not feel guilty if they can't breastfeed. Whatever people can manage to do. If you're one of these people who can manage to breastfeed a child for 2 to 3 years or more, as some women do, more power to you. I think at that point, I think once they're old enough to get the actual COVID vaccine or other vaccines, the benefits may sort of not be as great from an immune standpoint. But so certainly within that first, for COVID, 6 months, for other vaccines, first few months of life, there's protection wherever you can get it. And so it's not so much like a minimum dose as just do what you can.
So there was one question and a statement. So I know that there isn't any data about long-term effects. There is evidence that COVID can alter the brain. As an elementary school educator, I'm wondering, what is the possibility of seeing students who will have difficulty learning because of COVID? And what do you think those symptoms will look like, and how can we help these students?
It's a really great question. So there was a study, I'm trying to remember, I want to say it was in Nature, that just came out not that long ago, that had really, really, eye-opening in sort of both a kind of profound but also bad way, data about brain changes in adults with COVID. And they were mostly older adults, and more of the brain changes were seen to increase with age. Sort of the difference between COVID and non-COVID brains seemed to be more as the adults got older. So not clear if that data holds for kids, but it definitely caused physical changes to the brain. It caused volume loss, fewer neurons, fewer connections between neurons. On the one hand, kids' brains are still developing. So even if there is some damage, there's more plasticity and more potential for that damage to get fixed. On the other hand, if it can cause that in adults, it may very well be able to cause that in kids, and fewer connections could absolutely lead to difficulty learning. Really, really, really hard to know what that would look like. I think, the things that I've seen in the handful of kids who've come in concerned about post-COVID symptoms have been sort of a feeling of kind of slowness, having more trouble with homework than they used to, kind of having to reread things. People will use the term sort of brain fog, which it's hard to know what that always means to different people. Sleeping more could be another one. And I think how to help it, I mean, without knowing what the underlying problem is, I mean, certainly having, seeing a neurologist, seeing a psychologist or psychiatrist to make sure that depression or anxiety isn't a factor, because those can absolutely cause those symptoms in kids. And kids especially will have kind of somatic and concentration and those kinds of symptoms even more than adults often will. I think doing the kinds of things you would do for any kid who has learning difficulties, trying to give them more time for things, trying to help assign a tutor, trying to do a more detailed assessment through, depending on the age, early intervention or the school district or a psychologist to try and figure out where their deficiencies are. Every kid's going to be different. It's a great question, and I think it's something we're going to be kind of dealing with probably for the next few years. And I'm sure there'll be tons of interesting studies that come out, but we don't know. And I'm worried as a parent and as a pediatrician too, but.
And I think a lot of it is also going to be those confounding factors of, well, is there anxiety and depression also due to COVID, and not necessarily COVID infection, but just the pandemic, and trying to tease all of that apart too. Saul, just to clarify, so, in some of the data that you showed, is it a fair statement to say that in areas where vaccine rates are low, that's where mask adherence is likely more helpful than in areas where there are higher vaccine rates?
Yeah, definitely. Definitely. I think, having the total package of masking, vaccines, good air exchange, good ventilation is ideal. Anywhere where one of those is less present, the other two are going to be that much more important. So if you are in a poorly ventilated room in an area that has a low vaccination rate, like wearing an N95, if you can find one or two N95 would be fantastic, and trying to be more rigid with masking. It definitely is the case. I just see in the chat a question about fewer colds and other infections. Yes. We have been seeing that anecdotally, and if you look nationwide, we barely had a flu season last year. We barely had an RSV season. They saw the same thing in Australia, in other places. Absolutely, for a lot of, especially the other viruses that aren't as transmissible and aren't dependent on such tiny particles and are more like bigger droplets that someone's got to cough or sneeze into your face, wearing a mask and standing further apart from somebody absolutely will help with infections. That first sort of the second wave, I guess it was, that kind of November, December kind of first real full winter with COVID, the only virus we saw in kids in the hospital was enteroviruses and rhinovirus, which are both transmitted, but more by touch and touching objects than, or as much by that as they are by droplets. And especially in like daycare age kids who, they were washing their hands as best they could, but they're touching things in daycare. But yet all of the things that we know are transmitted by people sneezing in people's faces and droplets and things like that vanished. And they're coming back now as people are getting more lax with masks. So, that masks helped with fantastically. And so if there's a reason to keep wearing a mask, you probably will get sick less. I noticed in myself, I got sick less these past couple of years.
I think it's important also that in other cultures and parts of the world, pre-COVID pandemic, people were masking in more crowded areas, just that was the norm. So, or areas of poor air quality, those sort of things. So it's not that masking was a new thing, just with the pandemic in other parts of the world, at least. So two other questions. Do you have a prediction from a fellow 98er, so you can blame her? Do you have a prediction, Saul, about whether the data is good enough for FDA approval of the Moderna vaccine for kids under 5? And any idea of a time frame of when we can expect this?
So, it's interesting. I'm not, a vaccinologist. I do think it will probably be approved by the FDA. I wonder, it's sort of weird. You get the FDA panel that talks about it, and then you get the CDC ACIP panel that talks about things. And there are often some really crotchety docs, especially some not peds docs who are on those panels, if you listen to the calls, who raise some good points and some who raise some not so good points because they listen to themselves talk. And then despite all this back and forth, the vaccines do seem to get approved. So I think even with the efficacy being low, I think because it's better than nothing and it has a decent, even 50% is still substantial efficacy, seeing this, given this peak we've been seeing in kids, younger kids coming into the hospital. If you can reduce that by half within a vaccinated population, I think it'll probably get approved. I think what I read was that, I mean, your guess is as good as mine for the time. I'm reading the same info you are. I think I read that they had already submitted it to the FDA. It usually is a few weeks for them to review it. They've been reviewing quicker with the COVID stuff. Or at the end of March, maybe end of April, maybe a month based on past vaccines, but your guess is as good as mine. And it could be that there's some piece of data we haven't heard yet that they're not trumpeting in the press, and then the FDA reviews it and oops, there was a thing they forgot to mention. And now, now it's not approved anymore, so who knows? But that'd be my guess. Don't hold me to that. I wouldn't put any money on it.
And then do you, we won't hold you to your prediction, Saul, don't worry. And also, this is also an opinion question. Do you think masking in school should continue in flu season?
So, it's a good question. I think as an infectious disease doctor, yes, I think masking would be great to prevent all the lost days of school, lost days of work for parents, hospitalizations that still happen in kids. We have deaths still from flu for kids. The tricky thing is from a sort of social and developmental standpoint, like what are we like as people growing up, and especially at a younger, day school, a preschool age, if we can't see the lower halves of people's faces all the time. I mean, we depend so much on visual cues for communication. Is that gonna affect social development? Is it going to be more of a problem, especially for kids who are autistic, who aren't going to focus on the eyes, but may look at other parts of somebody's face? These are reasonable questions. So I don't know that I would say every kid should mask 100% of the time, all the time, but would it help us from an ID standpoint and from a sort of general health and wellness standpoint if kids were masked during flu season? 100% it would. And again, there are Asian countries that do that, and the data is there that they have fewer cases. The other issue is, wearing the masks appropriately, though that matters a little bit less for less contagious diseases like flu.
For those of us on the call who've had kids in daycare, I mean, it's parents who get sicker from what the kids bring home than the kids themselves, right? So it's like you said, lost days of work for parents too.
Well, they shrug off a fever of 101 or 105, and we get a fever of 101 and are on our butts for 5 days from it. So yeah.
I guess we'll have just these last couple of questions and then we'll be out of time. But thank you all for being so engaged. So if the Moderna, so for somebody with a 4-year-old, if the Moderna vaccine is approved, would there be any reason to wait in the hope that another more effective vaccine becomes available sooner?
Yeah, I know. I mean, I think I would go with whatever vaccine becomes available when it becomes available, assuming the safety data is there. It's going to be a while for the Pfizer one. The Pfizer one will probably be 3 doses for some of the ages, and impossible to know whether it'll be more effective or equally effective to the Moderna one. So I think you go with the vaccine you've got, and if you end up revaccinating and giving a booster, we do that. But I would go with the one that's there, yeah.
Because I do believe this is probably the way we're going with boosting, similar to the flu vaccine every year or season. Is there any reason to believe that there's any danger in boosting periodically over time for children or adults?
I mean, no. The one caveat to that is we don't have great data about boosting and myocarditis. Though we didn't see the same spike in those in those events in the hospital when the booster got approved for 12 to 16-year-olds. So that gives me hope that maybe because their immune system had already seen it, it didn't kind of do the same thing. But other than that sort of unique situation, there, would be no different than getting a tetanus booster periodically. It's just going to help your immunity, really.
Great. And then just one final question. As a pediatrician, how would you advertise the proper way to wear masks, since it seems like a lot of people don't understand what airborne means and needing to cover the nose? So how would you advertise so the average public understands it?
So I saw a great, I've seen a great cartoon that did this, so I cannot take credit for this analogy, but it was a picture of somebody with their underpants pulled down, so that was a male, so that their private parts were hanging out over the top of the underpants, and basically said, would you wear your underpants like this? If not, then don't wear a mask like this with your nose out. And so I think it's basically like, if you wear underpants so that your private parts are covered, you should wear a mask so that every part of your face that isn't your eyes is covered. In terms of an N95, that we do complicated fit testing for in the hospital, but a good rule of thumb is to find one that fits. You want to take something that's really, really strong smelling. So a good one might be like if you have ammonia or bleach, as a cleaner in the house, and have someone open it near you and see if you can smell it. And if you can't smell it through the mask, then it's a good fit. If you can, then it's not a good fit. Finding one that'd be sized for kids, it's going to probably be a small, and it's probably not going to fit younger kids at all, because I don't think they really make child sizes for those. So your mileage may vary with that, but it's a good rule of thumb. No, don't let your facial private parts hang out, and you shouldn't be able to smell stuff if you're wearing an N95.
Thank you so much, Saul. Thanks everyone for your time and attention. Kinshasa, did you have anything else to close with? You're muted.
Excuse me. No, thank you all for coming. It's been a really important discussion and a lot of good material that was covered. Thank you both.
Thank you. Thanks for having me. Thanks for coming, everybody. Hi to everybody, but hi to fellow 98ers.
Have a great night.